Dr. Barron, I think we should start. Good morning, everybody. Thank you for waking up early and participating in this early stroke conference. We have as our speaker today, Dr. Scott Barron. We all know him. We worked with him for years at Mercy San Juan and I think Mercy General. So without further ado, I give him the microphone. Dr. Barron.
All right, thank you. Thanks for the invitation, Lucian, to speak. And so we're going to broach the topic of PFO detection and the guidelines for closure for embolic stroke from that origin, and also touch on AFib detection. And ultimately, Lucian asked me to talk about some of the new left atrial appendage closure devices and their role in stroke prevention. So with that in mind, we're going to go forward. So the TOAST criteria, this is on your screen. I can move. Thank you. The TOAST criteria. So this old study that looked at a heparinoid, but kind of looked at the various idiopathologies of stroke. So if we look at the blue, that's the type of stroke we're going to consider today, which is cryptogenic stroke, and it's maybe honed in on. This slide shows the ischemic subtypes, but also the strokes related to cardioembolism versus those that are embolic strokes of undetermined source. And that's what we're going to try to discuss today. But a lot of you all know this data better than I do. I'm kind of reviewing a little bit for the cardiologists that wanted to listen in as well. But embolic stroke of undetermined source, ESUS, is what, we all are, the quandary that we all kind of face, both as cardiologists and as neurologists. How do you identify these, and then what is the right thing to do in terms of working them up and treating them? So you obviously look at the size of the infarct and its location on scanning, whether there's extracranial or intracranial atherosclerosis. I'm not sure that an internal carotid that's 50% is likely the cause of a stroke. It may be an epiphenomenon, especially if it's just a layering of atherosclerosis without a friable substrate, but that's a different discussion. And then if there's no other major source, when we look at these patients, we kind of consider, as you do, where they have AFib, there's some type of intracardiac thrombus. If they have valve prostheses, you can look on the echo, but obviously better transesophageal echo for myxomas or other tumors, fibroelastomas, where they have mitral stenosis, where they have low EF and perhaps LV as a source of thrombus, and then thromboembolism and vegetations. And Bradley and I reported a patient with cancer who had non-bacterial thrombotic endocarditis and source had presented with a stroke. And so these other things like arteritis, dissection migraines, drug abuse, which is not an uncommon thing somehow at Mercy San Juan, all are considerations. So this also shows this interface between what may be prothrombotic disorders, which we need to evaluate, and everybody does seem to be pretty careful about that evaluation, and the patent foramen valley we'll talk about obviously in depth. We sometimes see disease of the arch. I have a patient that has aortic stenosis, coronary disease, but she has an ascending arch atherothrombosis. She has a highly mobile plaque that is in her ascending aorta. And so she really isn't a candidate for almost anything to be done, but she is a risk candidate for a stroke. But she has to be treated medically. So the other issues, especially atrial cardiomyopathy, may be coming into its own. We don't do it here at San Juan. People are looking at left atrial strain and left atrial mobility in terms of its potential. If the left atrium really doesn't contract well, is that a source for some type of thromboembolus as well? And let's move on. So, we know that there are lots of things we should do. We want to know if the patient has a cryptogenic stroke. And so you all do this very well. The brain imaging, the vascular imaging. Scott Kasner said maybe even not just ultrasound, but maybe more robust imaging for the carotids. And of course, intracranial disease is also an issue I think we see more of nowadays as sort of stroke etiologies. But then we come to the cardiac evaluation and transesophageal echo with bubbles or TEE with bubbles. I think that, from my standpoint, the data sort of are fairly supportive of the fact that if you look at just transthoracic echo with bubbles, there's you miss a lot of people that do have patent foramen ovalis. And this is what, I think we were talking about offline before the meeting started about having a committee to talk about the patients and their risk benefit for various strategies from a cardiac standpoint to help, solve neurological problems. And the TE is much more helpful, and having some type of increased pressurization in the right heart, whether it's Valsalva or you press on the right upper abdomen. But, PFOs can either lead to blood flow across the PFO or not, depending on the pressure difference between the right heart, the right atrium, and the left atrium. So we can talk about that some more. Of course, rhythm monitoring has a life of its own nowadays in terms of how much to do and what that means. And I'm going to try to touch on that. So we've seen this patient, these kind of patients. I've actually seen the thrombus in transit. So you can imagine small thrombi, which develop maybe in the veins of the legs. We have those valves in the leg veins we don't think about too much, but behind the valves, there's a relative hypoxic state, which leads to increased risk of thrombosis. And then that's why some of these people have these little blood clots that then go to the right heart and can traverse the PFO. If there's an opening and pressure in the right heart is right and over the left, then you'll see potential for this clot. And we've seen these clots passing through the PFO, this clot in transit. There's a slide on that a little later. So if you look at the right bottom one, I don't know if our names are all in the way, but where there's a little dot there, and that's where the foramen ovale is. Oops, let's go back. Where the foramen ovale is, I'm trying to mark it with my, and here's the fossa ovalis. So then if you go to the left, you can see here, this is the atrial septum and the septum primum and the septum secundum. And between these two, there's a space. If the space is over 2 millimeters, that increases the risk that a PFO may be significant. And you can look at color Doppler of the blood going through here, kind of an eccentric blood flow. If we put bubbles in, we'll talk about that some more. If we put bubbles in the right heart, the agitated saline, then we can see the bubbles go through this atrial septum and go into the left heart. You can see them usually here. And the amount of bubbles passing through tells you something about the size of the shunt and the significance of the PFO. So normally, of course, our lungs filter all the blood that comes from the right side, the venous side. The blood goes through the pulmonary vasculature, through the lungs. Little particulate matter is generally filtered in the lungs, and the blood is relatively pristine when it comes back to the pulmonary veins into the left atrium. But if there's no filter, if there's a hole in the heart that lets blood go from the right side unfiltered to the left side, then thrombi can traverse into the left heart, into the aorta, into your brain vasculature, into the lower. So we see sometimes even cardiac emboli, people that have had AFib. Sometimes the coronaries are where the blood with clot goes, and we'll see thrombotic occlusion of a coronary that is the cause for heart attack. So here's this thrombus in transit through the PFO. You can see here on the left upper side, here's the right atrium, the left atrium, here's the aorta, the intraatrial septum, and here's where the PFO usually lives. And there's this thrombus here. You can see a picture. It's been fished out of there. Obviously, this was a surgical experience. And for you all, you see this all the time. So here's the cutoff vessel. And then you put into one of these stent retrieval devices. And here's the blood clot. This is a 29-year-old woman who came in with a stroke. And we've all seen these patients. We did last year fix PFO for a 32-year-old. We've had patients that, interestingly, we had a young woman who was in her 30s with 3 or 4 kids who came in with after COVID, high D dimer, had DVT, PE, blue clot, patent foramen ovale, had a stroke, had to do a craniectomy, and she ended up recovering pretty nicely. But so these patients have the potential for disaster. And I recently saw a patient in the office who had DVT and PE previously, was taken off her anticoagulant and then had recurrence, but had a PFO, and she got a stroke related to that. She was an older woman. So interestingly, this is something that we should think about perhaps more often than we do. And what I was saying is, I think that the TEE is a better way to go with bubbles, and you need to increase right-sided pressure. You can even have people blow on a straw, and that will simulate Valsalva. People find it difficult to know how to do a Valsalva. So if you have them blow on a straw, that'll increase right-sided pressures and then maybe show right to left shunting that wouldn't have been seen before. So again, if you have, as in this case, a 49-year-old man, he had a stroke. He was an occasional cigar smoker. He had a small right cortical infarct, but the carotids were okay. EKG sinus, echo showed a PFO, lipid levels are okay, no diabetes. So obviously he's a pretty high risk person that probably should get a TEE with bubbles as a next step. So, you know, you guys know better than I in terms of determining whether something may be lacunar or some type of embolic stroke. And so we do the imaging. Obviously, if they have a lot of abnormalities, it may suggest cancer, some other etiology. And this, again, is something we should think about. I think we're all pretty good about looking at thrombophilia, antiphospholipid syndrome as one, but also dissection. So there are garden variety strokes, these small incidental strokes, rather PFOs, garden variety PFOs. 25% of people or so, maybe a little more, have a failure of the atrial septum primum and secundum to fibrose together, and they have potential for shunting. That may be seen after certain conditions. We had a physician who had an aortic valve replacement, and then afterwards he had latitynia orthodeoxia, where he sat up and he desaturated because it opened up the PFO that wasn't seen in the OR, even with the bubble study in the operating room. That wasn't seen until he sat up after his surgery. So these can be somewhat challenging. There are some more challenging subsets, and especially if they have extreme atrial septal aneurysms. So again, you have to have a higher right-sided pressure. Blood moves from, higher pressure to lower pressure. So it's not just to have a potential hole there, but you have to have the higher pressure. And if your eustachian valve is still, many people have a eustachian valve, and that can direct the blood to the patent to what would be a patent foramen ovale. And so, in utero, and that's how the blood gets across the upper part of your body. So there still can be people with significant eustachian valves. It may increase your risk of shunting if you do have a PFO. So we can do transcranial Doppler. It's actually very sensitive, perhaps more overly sensitive, but at least if you see something, and you may want to hone in with the transesophageal echo and bubbles, and with the right heart pressurization, as I mentioned, and to increase the yield. So how do we do it? We take a couple of syringes. People sometimes like to mix it with air. When I started doing these in the 1980s, we did the University of Washington way with just bubbles, but you can mix some blood in there with a little bit of air in the tubes, go back and forth and make some foam without any macro bubbles. You don't want to inject macro bubbles, but it does work pretty well. So let's switch gears a little bit and talk about probabilities. So obviously, a person that shows up with this stroke and has a PFO, what is the relationship of the PFO to their stroke? Is it true, and related? Well, there's this risk of paradoxical embolism score that looks at a scoring system to help make that determination based on probabilities. An 80-year-old with hypertension, atherosclerotic disease, diabetes, hyperlipidemia, they're going to have a low probability that their PFO is related to the stroke, and more probable that something else is. So if they have a low score, low probability, low score, it's if they have all these things missing. So they don't have hypertension, diabetes, prior stroke, etc. And if they're over 70. So if they have a 0 rope score, their risk that the probability that their PFO is causing their stroke is extremely low. On the other hand, if they have a young person who's, let's say, 20 with no cardiovascular risk factors and they have a PFO, then their risk obviously is a lot higher, that it's true, and related. And so if you can see that if they have a high rope score, high risk, high probability, then that PFO attributable risk is a lot higher. So what increases that risk, let's say they had a PFO and they're a young person without risk factors, well, how high is their risk? Well, if they have other comorbidity features, like they have an atrial septal aneurysm, that mobile atrial septum that either moves 10 millimeters from the midline or 15 total excursion, that's an atrial septal aneurysm, and that's associated with the higher risk of a PFO causing a stroke. And if they have a large shunt, sometimes you'll see just a little bit of bubbles going across NT bubble study. You want to see it early on, not late, because late maybe it's just going through the pulmonary vasculature, little bubbles. But if you see it early on, like 3 beats, heartbeats after injection of the bubbles, then it tells you more likely that PFO is really the cause of the shunting. And you can see a small shunt, 5 bubbles, or you can see a massive shunt. Bradley Sabra had a patient who a couple of days came in with shock, or rather trauma and shock, and had been on the ventilator with high PEEP. It was difficult to ventilate because he had lung contusion. And the surface study showed massive bubbles. So as soon as you injected the bubbles, it just lit up the left heart as fast as it lit up the right heart. It had the atrial septal aneurysm and a gigantic shunt while he was on PEEP. And then days later, there was almost no shunt because now his hemodynamics were improved and the right-sided pressure. So these things are labile, and I think that understanding that nuance is really an important interface for cardiology and neurology. So these, when you say no shunt with bubbles on a surface study, it may be missing the mark. So if you have somebody with a high rope score and a PFO, it may bear a little bit more scrutiny than just the surface study. Something to think about, and that's why Lucian was saying maybe as we get together and talk about some of these patients, that would be some of the insights that we both can share. So we're just alluding to shunt size, atrial septal aneurysm does matter. If you look at the studies, and we'll go over these a little bit more later, if you look at the studies, then the studies do show if you have a large shunt and atrial septal aneurysm, that there's a relationship and that closing the PFOs seems to have a higher yield. And if you have a small shunt, like you just see a little tiny PFO and a patient that may have a low rope score, an 80-year-old with smoker, then, that may be not so much true and related, and obviously not so much benefit. And antiplatelet therapy seems to be better than anticoagulant therapy in these patients that are been recognized. And these studies were done with warfarin and not the direct oral anticoagulant. So, maybe a little anachronistic from what we normally use nowadays in terms of therapies. So let's look at the Pascal classification. PFO-associated stroke causal likelihood Pascal classification system looks at probabilities again. So if you have a high rope score, a young, healthy person, and they have a large shunt, let's say more than 25 bubbles, and they have an atrial septal aneurysm, the likelihood of the PFO causing their stroke is quite high, and closing these people in the absence of contraindications would be probably quite beneficial. If it's an older person with a lot of risk factors that don't have a septal aneurysm, have like a 2 bubbles coming across, even with Valsalva, maybe that's the person that you can not close because the risk of closure and comorbidities, and even though they're quite small, it's probably not related. So maybe not to do that. So if you look at these analyses of the data in terms of favoring closure on the left side of the whisper plot, if they have a high rope score, young, healthy people, closing is good. If they have Pascal, which increases the yield in terms of understanding that risk, the probable Pascal high rope score person is going to have a dramatic benefit. So you can subset the patients in your mind this way. If you do close the patients in these higher risk subsets, then you do see significant relative reduction in recurrent events. And several of the trials respect, reduce, and close. There was a significant reduction in recurrent events by closure in these patients that are higher risk. Obviously, sicker patients do better with an appropriate intervention. Here's another way to look at the data. So you're looking at the baseline characteristics, which correlate with the magnitude, benefit, complications, looking at Pascal, incorporating the rope score. And so if they're the probable patients, younger patients, bigger shunt, atrial septal aneurysm, you have about a 90% relative risk reduction over 2 years, 2.1% absolute risk reduction. It's a slight increase in atrial fibrillation compared to the baseline. Late AFib is rare. A little bit of AFib early on is not uncommon. But if you look to the right where the patient's unlikely to have a PFO causing a stroke, then the benefit is obviously not there, and the atrial fibrillation risk is higher. Of course, atrial fibrillation in these older patients with comorbidities is a much more common occurrence anyway. About 20% of people over 80 in America have atrial fibrillation, so pretty common in our elderly patients. So we did all these studies. I mean, early on, the RESPECT trial, for example, that Saver and Carroll did, the first number of years of study didn't show real benefit, but there's some caveats because with intention to treat analysis. And for the patients that were in the treated arm, the PFO treatment arm, actually were not treated. One didn't have their PFO closed, and they had heart surgery, bypass surgery. They got a stroke after that, but they were in the intention to treat arm. So maybe even the early trial data analysis would have shown benefit if they looked at the on treatment versus intention to treat. But suffice it to say, later on, as they accrued more patients and Follow for Respect, which was published in New England in 2017, it did show significant benefit, as did some of the other studies. And the high-risk patients, like we're seeing in Defense PFO trial, we'll talk about briefly, showed indeed that they all did better. They have a large young person, high rope score, probable on Pascal. They all did better with closure. Here's a Defense PFO trial. It's an open label trial, 120 patients, either getting PFO closure or medical therapy. So they had to have an atrial septal aneurysm, high degree of hypermobility of the atrial septum, or the PFO had to be 2 millimeters in size. We looked at that size between septum primum and septum secundum in that first couple of pictures. And so the PFO, the size of the PFO does determine its risk as well. And then they looked at the primary endpoint, including stroke, vascular death, TIMI-defined bleeding during 2 years of follow-up. And there are no primary endpoints whatsoever in the PFO closure group in this high-risk group of patients, and really only minor adverse events in the device group. So dramatic benefit in the Defense PFO. So that leads us to guidelines. And so if you look in the middle, the HAASA guidelines from last year changed the landscape for this whole group of patients by officially recommending that if patients are less than 60, that's based on the trials, including Respect, did not have a lacunar stroke, had high risk anatomy, as we're discussing, large number of bubbles crossing on TEE, atrial septal aneurysm, but the non-high risk patients, it sort of was a little bit obviously ambiguous as to whether they're closed or not. And that's what, discussions between all of us will yield which patients were probable to benefit. Who knows for sure, but you don't want to have people have recurrent strokes because we're nihilistic about something that's the cause and benefiting them by treating them with more alacrity. So how about older patients? The European guidelines are now up to 65, but I'm not sure how much data that's based on. This small study looked at older people, and here you can see the mean age was 67 and a half. Looked at a small number of patients, comparing them to the younger patients, and here's a difference, 388 patients over 60 years of age, and then the traditional patients that are less than 60 based on Respect and the other trials. So they still had benefit, 0.59 events per 100 patient years in terms of stroke reduction, but here's the benefit in the younger patients. So, but still, this is pretty good benefit. The difference in the benefit was 6.1. So much more benefit in the younger patients than the older patients, but still significant benefit for risk reduction compared probably to the non-treated patients. Not all old patients are the same. I'm turned 70 in June in Santorini for my birthday. And so I kind of would like to be felt as being a younger patient, but I don't know, maybe they just all write me off. You guys saved me once, so I don't know. But even in these very low risk patients that don't have risk factors, don't have a high rope score, but there's no other cause except for a PFO, as I was saying, sometimes it's hard to tell the degree of shunting without various maneuvers, and even those various maneuvers sometimes in some conditions may be more dramatic than others. So food for thought as to who to close, and even retinal artery related stroke may be PFO related as long as it's happened once and not recurring in the same eye. So things to think about in terms of these lower likelihood patients. So how do we close a PFO? That picture of the heart doesn't show very well. Should we open up their chest and do open heart surgery? And we tend to shy away from that these days. So how do we do it? We do it from a transcatheter approach. And what do we use? So there are various devices that were studied. We use this middle device. I've used this for decades now. It's called the Embolic device. There's a PFO specific device that's FDA approved, and there's some other devices. And this Embolics are now St. Jude category that have good benefit, years and years of experience. Almost no thrombus on this device ever in the studies. So seems tried and true, and it's relatively easy to deploy. And this is the other Gore device that's approved. And, some people use this as merits, and maybe there's some nuances for one patient versus another for which device. So, the things we worry about are the etiology of atrial fibrillation that may be device related, rhombus, which may be on the device, long-term durability. These devices seem to be tried and true for decades. I've been following patients for decades, and they seem to be good. Erosion is a possibility, usually for atrial septal defects, less likely for PFOs, fractures. So no one's done any head-to-head trials, and they never will be done for the devices. And so these are two devices that we use, Embolic PFO, now St. Jude, and the Cardioform Gore device. Both seem to have a good track record for success. So does PFO closure cause AFib? We put the device and now they've got AFib. So now we have a new misery to deal with. And so generally you can see a transitory occurrence of AFib in about 4% of people, maybe less, obviously, when you go forward. And it depends on the substrate. Obviously, the older patients we may be pushing limit for in terms of benefit may also have a higher AFib occurrence. Well, how do you find this out? How do you find out whether they do have AFib or not? You can do the EKG, they're monitored in the hospital, and then they go out. I remember one of the patients I saw in the hospital, they had a stroke, and they had no atrial fib the whole time they were monitoring. One young woman, about 55. And so then she came into my office, and in the office for their first follow-up visit, she was an AFib, totally never detected before. And so she got her PFO closed. It was truly related. Or rather, she didn't get a PFO because she got her atrial fibrillation treated with anticoagulant therapy. So how much monitoring should you do, and what does it mean? This is very controversial. You can do the Zio patches at pretty high fidelity for a couple of weeks. We have been putting in implantable loop recorders. One of my patients whose brother is an internist at Mass General. So he had clearly large PFO, large shunt, atrial septal aneurysm. And so we went back and forth. I said, I think he should be closed. And his brother, well, he wasn't so sure. He talked to his buddies in cardiology at Mass General. So they made me put in a loop recorder. At the time I was closing his PFO, they said, oh, that's a good compromise. So got a loop recorder, but he had a big PFO and he's had a couple of strokes in the past. And so I think you can look at monitoring, and longer monitoring yields more atrial fibrillation, just obviously the case. The longer you monitor, the more the occurrence. But what does it mean? What does it mean to see atrial fibrillation? How long does the atrial fibrillation episode have to be? and to be meaningful and to be treated. So one study looked at this loop study, which was recently published, and it looked at patients who had no AFib, an inclusion criteria, had some risk factor like hypertension. And then they defined AFib as you had to have 6 minutes of AFib, and these patients had an anticoagulant recommended, so that they were found to have AFib. There was about 1,500 patients in the loop recorder group and 4,500 in the usual care group. Of the loop recorder group with those criteria, 6 minutes, 477 had AFib, and there were AFib diagnosed in 550 of the control group. Of course, there's a lot larger N in the control group. So if you looked at what happened for stroke outcomes, 4.5 in the loop recorder group had a stroke, 5.6 in the control group had a stroke. There's a hazard ratio of 0.8, but it didn't reach statistical significance, p.11. So one of the conclusions was that loop recording increases in a 3-time increase in AFib detection and in the use of anticoagulation, but overall there wasn't really much of a difference in the benefit in reducing stroke or systemic arterial embolism. So I think it raises more questions, and somehow it's not, intuitively obvious that that's true, or maybe we need to think about a longer time for AFib occurring to be meaningful. But this, obviously, these studies raise more questions and give definitive answers, and at least it's an interesting study to think about. So should we close PFOs that seem meaningful? And the new devices, you should have almost zero complications for PFO closure with the devices that have been FDA approved. The Amplatzer device, which we've used for decades with really no complications. And so if you took those patients and you gave them the device, plus we give aspirin therapy, in the RESPECT trial, they gave aspirin to most people, but after 6 months with PFO closure and the PFO closure device from Amplatzer, many of the patients stopped aspirin after 6 months, but we continue it. And so if you use that strategy, you're kind of reduce recurrent ischemic stroke over 5 years from 6% to 1.8%. And you should really not have complications. It's all on the venous side for entry. You do go across the atrial septum, across the PFO, so you're in the left heart. So stroke risk is important. Preventing air embolization is very important. And so the device is pretty safe to use, and nothing should ever be taken lightly. And you can have probably an increase of AFib earlier, and that tends to be a lot less so late post intervention. So Lucian asked me to talk about, let's say the patient has atrial fibrillation. We're switching from PFOs here to just atrial fibrillation patients, but cannot take anticoagulation because of bleeding risk. I would say as a caveat, the devices that were placed do require anticoagulation, at least the Watchman and the newer Watchman Flex, but there's another device from St. Jude called Amulet, which doesn't require anticoagulant therapy. And most people now, for the new Watchman Flex device we'll talk about, require dual antiplatelet therapy, even though it's indicated to use anticoagulant therapy. So with those caveats in mind, there are some new strategies. There are 2 devices FDA approved, Watchman and its newer counterpart Watchman Flex, which is a better device, and the Amulet. So let's talk about the Watchman. This was the first device on the scene. The guys down at General put these in. Dr. Ariana has put in a large number of these devices, and they're relatively safe, especially the newer iterations called Watchman Flex. And they're relatively efficacious. And I've had a number of patients that have had recurrent bleeding episodes and atrial fibrillation. So they're AFib, they're off their anticoagulant, and they stroke. And then they get back on their anticoagulant and they bleed. Some of these are angiodysplastic bleeds. So they're hard to evaluate and they're hard to treat. So these patients may be very good candidates for this type of device closure. So our population's aging, atrial fibrillation is becoming more and more prevalent, and the stroke risk is 5 times greater when you have AFib than in the normal population. Again, about 20% of 80-year-olds may have AFib, so we're starting to get a very large number, at least 5 million people nowadays in the US with AFib. So this Watchman device is the device to close off the left atrial appendage. So as you know, the left atrial appendage is this vestibular pyramid-shaped structure sticking out from the left atrium. It really serves no purpose, but normally it contracts along with the left atrium if you're in normal rhythm. And when you're not in a normal rhythm, it just undulates around and the blood floats around in there. It's like, water swirling behind a big boulder in a creek. The water kind of tends to get static. But when blood becomes static, as it does in AFib in the left atrial appendage, it congeals. If it just stayed in that left atrial appendage, didn't go anywhere, it wouldn't really be a problem. But sometimes a piece of it flies off into space and causes a stroke. And this is what you guys see. And these clots are more inspissated, hardened like little rubber balls. And so they don't really break up with TNK or TPA, whatever you want to use. And you kind of have to york them out of there. But these are larger, they cause generally larger strokes, and then closing off the whole internal carotid artery. And in any case, so you'd like to avoid that happenstance. If the patient can't be anticoagulated, in this early Watchman trial, they had no therapy versus a Watchman. Of course, they did have, for this iteration of the Watchman, they had to have anticoagulation therapy for a short time anyway. And so these trials showed obviously dramatic benefit, no therapy versus something closing off the left atrial appendage, that one. And there was less bleeding. So if you're giving people a whole boatload of warfarin, which can cause a lot of bleeding versus none, then bleeding risk goes down fairly dramatically. And even if you switch to the new direct oral anticoagulants, which we as cardiologists love, patients often will stop taking them after a couple of years. Excuse me. The early iteration of the Watchman, the first iteration, and the DOACs had relative equipoise in terms of benefit, but the Watchman Flex, which is a new device, is a better device, and we'll talk about that, and I'll show you a video. Early on, there were a lot of complications with the Watchman until they got better at it. Obviously, there's a learning curve, but even pericardial tamponade was not unusual early on in the studies looking at the Watchman placement, but more recent trials over here on the right side. And this is not with the new device, this is actually with the older device, showed that getting better at it really made a big difference in terms of decreasing complication rates. And so pretty favorable profile compared to no therapy. I'm going to skip through this. Much better as people have gone forward, having experience, and it's like anything, a little tricky to use up front. How about compared to warfarin? Well, certainly hemorrhagic stroke is pretty common, warfarin, and the DOACs decreased that risk by 50%, 50%. So clearly better in all these patients getting treated with anticoagulants in terms of hemorrhagic stroke risk. And certainly the bleeding issue favors Watchman. The rest doesn't really make that much of a difference. So here's a new device. This is called Watchman Flex. There's a video that should be like a couple of minutes. I'll let you watch that. I don't know. Tell me if you hear the sound on it or not. Narrate it. Can you guys hear that?
No, just
Can't hear it. So this device is a new device. It includes the left atrial appendage. This is what it looks like. It's better designed. These metal things are all enclosed, and here is this PTFE covering of it. And so the device is designed to occlude the left atrial appendage, and it's a much more elegant design than the first iteration of the device. And so what this is a Boston Scientific device. So it gets deployed like this, but you can recapture it, but make sure you place it. And instead of having these open metal things that can go right through the left atrial,
It's available in 5 device sizes with an allowable compression range of 10 to 30%.
The left atrial appendage with transesophageal echo. You pick the size that you think
Watchman
is the right
Flex
one.
pushes forward as the leader in LAAC therapy.
It seems to be obviously more effective in terms of a closure device than the old device, and it's safer. This is what the guys like to rock.
The physician accesses the patient's femoral vein.
Close these. So you go, in the right heart, you go across, you have to poke a hole through the left atrial, the atrial septum, go across with the device, and then you wire into the left atrial appendage. You make sure there's no thrombus in it to start with your transesophageal echo, and you kind of put your little deployment wire thing in there. There are various sizes and shapes to these, broccoli and chicken wing there, and so you make sure you size it right. You put your device deployment catheter into the left atrial appendage. You expose the device, shove the device in there. You make sure that it fits snugly so there's not going to be leaks. You can check that later. And then you deploy, once you're happy with the sizing, you deploy it on and then you can take it back if you don't like it. And then you can tug on the thing and make sure it's staying in place. It's so cold. Hug test. You can see on the left side that the intracardiac or transesophageal echo shows that there's good placement, it's stable, and it's not flying off in the space. You have good closure. You can look at color Doppler to see if there's any kind of leakage around there, which is much less so with the new device than the older Watchman device or even the Amulet. So it seems like a nice iteration, and it seems to be safer, more effective, and just better technology as you would expect from a second generational device. I think that's pretty much the whole thing. So yeah, so you supposedly you have endothelialization of the device, and then but you still have to give, according to you're supposed to give anticoagulant therapy after 45 days, and then just oral anticoagulants after that. But that's a work in progress too, because not everybody can really take any type of anticoagulant because there's a risk of bleeding, which is the reason you're putting the device in anyway with your patient. So that's all nuanced, obviously, what's best for the patient. So if I can get my next slide up. I have one final slide, but I'm probably not going to get back to it at this rate, am I?
Thanks, Dr. Barron, for excellent presentation.
That's pretty much it, and we're kind of at the end of the time anyway. So,
Dr. Barron, this is Reza. Can you hear me?
yeah. Yes, hi Reza, thank you.
Thank you so much for excellent presentation. I have one question, again, for the age. So what is your age cutoff for PFO closure? Is 65?
Well, I think as you get over 60, which all the US guideline says is, you become on a little bit shakier ground in terms of literature support. Some of these people we have done, certainly in their early 60s up to 65, now, I think you're amortizing the benefit over the ensuing years of the patient. So when actuarial survival was a lot less, and these studies were done, really started decades ago, then, your benefit is less if you're not going to live a really, really long time. But if, a lot of our patients are nonagenarians and some centenarians now, we just put a TAVR valve in one of my 99-year-old patients who's still dancing in her backyard when she's now 101. So I really think you have to decide and talk to the patient. And, I think that older patients probably do benefit if they're young for their age and don't have a lot of comorbidities that would give them another reason. If they have, carotid atherosclerosis, maybe that's not a good patient. And one of these patients that you guys had seen and came to my office and follow up had DVT-PE recurrent as her anticoagulation was stopped, and she also had a PFO and she got a stroke from that occurrence. But she's going to be on lifelong anticoagulation even if she has a PFO and had a stroke. She probably will just be on anticoagulation anyway, so she doesn't need to be closed. So I kind of think you have to look person to person, and that's why I think the committee idea that Lucian was proposing is really good, because some older people will really benefit, and some younger people less than 60 shouldn't have closure. Not that I think it's an easy procedure to do, and you can usually do it like in a half hour in the cath lab, would send the patient home. We usually send them the next day, but some people send home the same day. But I think everything is nuanced in life, precision medicine, that's the new wave, but I think that's appropriate. So I don't have an age, but I think that's going to be, collaborative between you all and me and the patient and their family. So that's how I would.
So I have one question, because I see some people, they do echo with a bubble study on any age, 80, 85 years old. Do you think it's reasonable to do echo with bubble study with any age?
Well, I mean, it's easy to do the bubble thing, but I'm not sure that you're going to do much about it. So I would say, maybe good to know, but as you say, I mean, it's a little superfluous, but in the echo lab, people just order echo bubble thing, and then in the echo lab, they do whatever they're supposed to do. So it's not really very well, it's not like there's some criteria. Maybe they should say, oh, but the patient's like, 70, we're not going to do the bubble thing. It's a waste of time and money, and someone has to inject it and yada, yada. So your point's well taken, but, maybe we should talk to, Didi and the echo people, and then just say bubbles don't probably need to be done if you're like 75 or above in any case. But that's a good point.
And except you, who else do the PFO closure?
What's that?
Except you, who else?
Just because and I've been trying to teach Bradley and OBI are interested, and they have some work to do for their privileging, but they're both up and coming young, smart doctors. And I think it's, like all procedures, it's fine when it goes fine. And when it doesn't go fine, you want like somebody who's done a zillion of these things to help you. So, I would say, later on, and Cosina and I probably will help the young ones. But I don't think Joe is doesn't have the same perspective about teaching as I do, but he's a wonderful interventionalist and certainly the go-to person in Mercy General. So, but we're the only two that I think do it. At least Dave Roberts does down at Sutter downtown, and Jason Rogers and Gagan Singh at UCD. I guess we're the only ones in town, I think, that do the procedure.
Thank you.
Okay. Thank you very much, Dr. Barron. Are there any other questions for Dr. Barron before I close the session? One remark. I totally agree with your position regarding the presence or absence of AFib. Maybe we are looking very skewed towards the presence of AFib, even when it has to be treated or not. And I want to make you aware that since July 2018, so for more than 4.5 years, we have the Arcadia trial. We are enrolling for atrial cardiopathy with antithrombotic drugs in prevention after cryptogenic stroke. One of your slides listed as a cause of ESUS, the atrial cardiopathy. So this idea that maybe you don't have to have AFib, but you have a problem with the atrium as a source, as a cause of the stroke. So we are enrolling, looking at apixaban versus aspirin. So if we can send you some inclusion/exclusion criteria and it's an NINDS sponsored trial. It's very slow to enroll because of all these biases in diagnosis and treatment.
Yeah, that's a tough group. And nowadays people are doing left atrial strain imaging, which is coming into its own, and that may be a way to identify some of these people. The echo lab, if there's a protocol, they should be doing more strain imaging for the LV, but left atrial strain imaging may be able to discern some of these people with higher risk. That might be beneficial as well. All right, but thank you.
Thank you so much. We will have the division meeting following. Give me 5 minutes to switch gear here. Thank you so much, guys.
All right, thank you, Lisa.